Okay, hello. I'm going to try to do my best to make this video brief, but I'm going to talk about a couple of ways to, just a couple of shopkeeping things that I think that would improve us operationally, a way to maybe reduce some of the use of supplies that we use, and then thirdly, I'm going to go over some of the pump functions. We might be switching pumps over the next 6 to 12 months, but I'm going to go over a couple of ways to administer DILT. So the shopkeeping things that I want to talk about are, I think it's worth all providers at Berrytown understanding that there's there's a lot of variety of supplies that we have, this being one of them. I don't think it's reasonable, nor do I think that everybody does this, that everybody goes through and they say, oh, this is the exact size needle that I have. So the point is that you might be confronted in a situation where you have to administer a medication or have to do something important for a patient that's not really that stable, and you don't have supplies that are quite what you're used to. So I just need people to understand that sometimes you have to make your supplies work because there's supply shortages, there's variety in the way that we order things, there's variety in the way that manufacturers update things. So you might have something that has been on a truck for a few years, and you might have something that was just ordered 2 weeks ago, and it's a different variety. So it is kind of your responsibility to be familiar with what you have. For example, the Ready Set Inject for intramuscular epi, I looked in all 6 of the ambulances the other day, and there were only 2 out of 6 of the ambulances that had enough of these 25 1-inch. That's what it says to use, 25 gauge 1-inch. Most of the trucks have these 25 gauge 1.5-inch. So it's not appropriate to not administer the medication to somebody just because you do not have a 1-inch needle. You would then need to take a 25 gauge needle and insert the 1.5-inch needle only 1 inches into the patient. So there's some variety in some of the supplies we have. That's one important topic that I wanted to discuss. The second is that I think it's worth in the morning when you do your truck check, taking the second pump that you have that's been plugged in and putting it into the infusion bag and then rotating the one out. It's not on the PAR list and it's not on the checklist that we fill out or anything that's being created, but if your pump dies, it's kind of on you for not checking your pump battery. So that's another thing. And then, so I'll get into just a couple ways to draw on medications, and then I'm going to go into specifically the Advantage vials because it's not given that much. And we'll go through a couple pump functions when we do it. So I'll try my best to do this one-handed. So kind of the way that I view this is use either a draw spike or an 18-inch gauge. Maybe a 21 would do it to draw up your medication, so it's got to be something large. Any smaller than that, your needle might bend, and it's going to be really tough to withdraw the medication out of the vial or whatever you're drawing it from. And then likewise, if you're administering medications to a patient, you need to put a smaller, like I would say no bigger than a 21, but we're trying to be, definitely 21 is that's still a pretty big needle. That's still a little bit barbaric, but if it's all you have and you're away from your ambulance and you have to administer life-saving medication to somebody, then you have to do that. But ideally, you're poking people with 23 or 25 gauge needles, and you're withdrawing it with something to the tune of 18 to 21 gauge so that you can withdraw it quickly and so that your needle doesn't bend when it goes through the vial. So that being said, I also have noticed we have insulin syringes, and this is probably left over. We have a lot of medication supplies from COVID days, and this is essentially a 1 milliliter, but it's in units, so that's kind of confusing. So I'm actually not sure the accuracy of these, if 100 units is worth 1 ml. So my recommendation is that if you see these on the truck, to just get rid of them. And sorry, before making this video, I didn't research this, but I don't know necessarily that this is 1 milliliter. And if you don't know, then you should probably take this off of your truck and then swap it with a normal one has graduations of 0.1, 0.2, 0.3 milliliters. That being said, I gave DILT a few weeks ago, maybe a couple months ago at this point, and it's the second time in my pre-hospital career that I've ever done it. So I'm going to try to, let's see. So the way that we're going to do this is you're going to take the vial and you're going to twist this off. Bam. Now you have this plunger in there. Likewise, you're going to take this off. Come on. Oops, see, we're already messing things up. Yeah. and there's a point to why I'm kind of taking so long with this. And then you screw this into here. Once that's in, you have to remove this plunger with your fingers from inside the bag, and it's a little bit finicky. And then it floats away. Kablam. And then you, of course, shake the medication out of the, and then your thing just floats there. And then obviously check your vial to make sure that there's no large amounts of residual medication on the side, because if there are, you got to shake it again. So it is important to know that this is not the only way that you can do this. If you have problems with the Advantage bag, or if we don't have Advantage bags, you can inject saline, like 10 cc's of it, with a 10 cc syringe. I'm trying to get people to use the plastic syringes more because we have a ton of them and they don't expire the same way that flushes do. So we can save a lot of flushes by just drawing up meds using accurate titrations and using just syringes, not saline flushes. So that's my first recommendation. And we have a ton of these too. So these are a lot cheaper than the plastic spikes are. So if you just consider that maybe we could save some money as a service if we start using some of the extra supplies that we have and not using so many flushes, because we know through all the emails and then a couple of emails that David and I have sent out that there are some supply shortages. That being said, we never really know when there is going to be a supply shortage of anything. So maybe we could be more mindful as an organization to try to use some of the extra supplies we have and maybe not use stuff if we absolutely don't have to, just as a general practice. And then once we do that, it'll be much easier to, for Natalie to accurately order supplies, because she knows truly what we're using month to month and we're not just throwing stuff away because it's expiring sitting in shelves, like stuff like this. So anyways, this now has 100 milligrams of diltiazem. If you administer 100 milligrams of diltiazem to a patient, you could kill them. You could even kill them with 50 milligrams. So please do not ever hang this from free flowing into a patient. That is incorrect. Additionally, you only have one spike here for tubing. There is not a medication port. So you cannot actually draw 20 milligrams into a syringe unless you somehow did it through the tubing. I don't even know. This should always go through a pump. So I'm going to show you the couple of ways that you can do this with our pump. And then if we switch to new pumps going forward, I'll show you that way. But we'll just put, yeah, I mean, you could probably like fit a syringe through there and draw stuff up, but it's just, I don't know why we would push diltiazem into a patient when we have a bolus function in the pump. And there's a couple ways you can do it. So I'll go through all three. So we're going to prime the tubing. You don't need to pop this because this is not a bottle. So let's get it primed. And then the other thing about this is I think it's pretty hard to, there's this little tab, and I've seen them break before. This is what you're hanging it up on. And I mean, I guess if that broke, you would just tape it, honestly. Just tape your bag like to the IV pole. It's weird, but you got to do what you got to do. So that's a recurring theme. Sometimes in EMS and medicine in general, you got to do what you got to do. And sometimes you don't have the supplies you think you do. Sometimes you have different varieties of supplies, and sometimes you're on somebody else's ambulance and they order different stuff. So it's your job as a provider to be familiar with sort of all sorts of equipment and then understand that differences, you don't need a ton of exposure to individual items to be proficient at them. You could just say, oh yes, I've used something similar to this. This is just a different version, but I can understand how it works, and then you can use it successfully. But it is your job to be familiar with your equipment. That being said, this is primed. Let me hang it up, and then I'll prime this pump. Where can I put this? Here, let's do this. I don't know, this might work. Yep, good enough. Okay. Okay. Might get some air alarms. I didn't do the best job flushing this line, but boy. And sorry for not rehearsing this, but, you know, here we are. Okay, all 4 are loaded. You can close the door. You can remove this whenever. The medication's not gonna. So, honestly, I don't know in EMS the way. I cannot find normal saline. I think you have to go to basic mode and just enter in your own parameters, which is why MedMath still is pertinent in EMS. So please, if you have, if you need to review MedMath or ways to, you know, it is your responsibility to know the concentration of the bag and to know based off the concentration, because this concentration might not be what's in the pump. With this particular bag, it is. But so, for example, some heparin bags are half of the concentration from Dartmouth and Gifford are half the concentration that UVM and Central Vermont Medical Centers are. So it is your responsibility to know that your units administered on this pump with a concentration that's twice as dilute, your administration would look on the pump like it is, let's say the patient's getting 900 units, you would have to put in 1,800 units on this pump. However, your check is to do your med math and then know how many milliliters per minute or per hour you're administering. If your milliliter, your flow rate is the same between the two pumps, then your medication is being administered the same way. So that is an important double check. If you're not using the same concentration, your milliliters flow rate has to be the same. So please double check that, because if you administer a medication at, especially heparin, if you administer even for like an hour to an hour and a half, twice as much heparin, you could cause a bleed in your patient. And you did that, and that's a med error, and that is very bad. So I go to the ICU, because I work there, so I know where things are located. So, because for normal saline, you can just click NS. That's how you find it in these pumps, and then it's all the way down at the bottom, 3rd page. There it is. So you're not limited to just doing ED or EMS or whatever, but you are responsible for knowing your concentration of medication and comparing it, because when you enter a medication here, it will tell you the concentration up here. If that medication is different, it is your job to do the math to verify that your milliliters per hour or milliliters or micrograms per kg per minute or whatever you're giving is the same as your protocols say. So if you have confusion with that, then I recommend practicing. So, okay, let's type in DILT and get started. DI, DILT, diltiazem, there it is. Let's see what the concentration is. This says 125 milligrams per 125 milliliters. This is 100 and 100, but we know that is 1 milligram per 1 milliliter, so the concentrations are the same. So there are 2 ways you can give your bolus. Let's say you're going to give 20 milligrams to a patient as a bolus. Maybe they're a little bit bigger. Maybe they're already on DILT and they didn't take it for a few days, so they might be less sensitive to it. You can do the math and say, okay, maybe I want to give 200 milligrams per hour. Yep, and you have to obviously go through the errors. So if I put in 200 milligrams per hour, I'm going to give 130 minutes, which means I'm going to give 50 in 15 minutes, which means I'm going to give roughly 18 milligrams in 5 minutes. Roughly 18 milligrams in roughly 5 minutes is relatively an appropriate dose and rate to administer diltiazem, because we know that we're only administering this until we see the change. But this is not the ideal way to do this. Or you can go into basic mode, and you would be responsible for knowing these calculations in basic mode if for some reason you can't find a medication in your pump. So let's clear program. Let's go back to DILT. The thing with DILT is that patients rarely need just 20 milligrams. They usually end up in the ICU for a few days, and they're usually on DILT for a prolonged period of time. And the general range for DILT is 5 to 20 milligrams. So if you just kind of go right in the middle and say 10 milligrams per hour is what the maintenance rate is going to be. So I'm going to go to DILT, and then I'm going to click OK. And then I'm going to put my dose. It comes at 10. Okay, good. So 10. Rate to be infused, 10. That's a long time. That's 12 hours of DILT. But if you give somebody 20 milligrams of DIL and then you just clear shut them off pre-hospitally, they might become tachycardic on you again. So you're not limited because you can give repeat doses of DIL. So your max, you will never, unless you're transporting patients for hours on DIL, you will never, with your bolus plus this maintenance, you will never exceed your protocol limit. So let's click OK on all of that and then click run. And then you might have to say, are drips flowing? If you don't click yes here, the pump will shut off and alarm at you. Now, that's their maintenance. Now let's do a bolus. Let's say we want to give them 20 milligrams. You're going to click bolus, amount of milligrams. And this is where, if your concentrations are different, this number is going to be different. So you have, if your concentration is not that, let's say that this concentration of DIL is 250 milligrams in 125. That's twice as much. That's twice as concentrated. So if you wanted to give somebody 20 milligrams and your bag was twice as concentrated, you'd have to type in 10 here. Okay, so I just need people to understand that sometimes you have to do the math. But let's say we're going to give somebody 15 milligrams of DIL and you want it to go in over 2 minutes. But if you wanted it to go over 5 minutes because maybe your patient's a little bit frail or they have renal problems or something, that's okay too. Value changed. Okay, yep. So 15 over 2 minutes, press run, run. Bolus infusing. And I have my cap on, so it's probably going to alarm at me. Yep. Okay. So once this goes in over 2 minutes, I'm going to put this into the trash can so I don't make a mess. And then just observe you have to cardiac monitor the patient when this happens. And then also take their blood pressure, a handful of times. So if they get their 10 milligram or their 15 milligrams over 2 minutes, and then they're still really, really tachycardic, you could give another 5 milligram bolus. Another important thing, if you want to safeguard yourself, if you say the maximum, the volume to be infused, which is one of the functions under the pump, VTBI, if you put 30 or 25 or 20 there, no matter how you set this pump, you will never administer more than 20 milligrams according to your concentration to the patient. So if you set your VTBI to the max that you would ever want your patient to have, you will not overdose them, at least not according to the protocol. Of course, you do have to be mindful that if your patient developed worsening symptoms, that you would probably want to shut the pump off and then maybe consider some more aggressive ACLS algorithms to follow. So if we give our 15, this is going to resort back after the 15 to your however you programmed it before. So in this instance, it's going to be 10 milligrams per hour. So not to draw this out, but like I said, if you did this over 5 minutes because maybe you think your patient's a little bit more frail, that's fine. Just justify your clinical reasoning. And, we're trying not to give medications too fast or too slow, but there's a little bit of wiggle room in the middle as long as you're trying to do what's right for your patient. And if you ever have any questions about how to administer medications or you don't remember, then call Med Control. Or talk to me and we'll review it. So now this automatically reverted back to its 10 an hour. Now let's say we're at a paramedic intercept in the valley and we haven't even loaded the patient before we did this, or maybe they're in the ambulance, and now you have a 40-minute transport because they request to go to UVM, which is an acceptable reason to, respect the patient's wishes and go to UVM. So at the end of all of this, you click pause or stop, and then you click review. I've given 15.3 milligrams of DIL. But after a 40-minute transport, this might be closer to 23, 25 milligrams of DIL. And for the amount of DIL that you infused into this patient, this is what you should put into your chart. So that's that. You can go to basic mode, which I honestly never use, but you can do it. You can set your infusion pump to be at like a really, you can mess with the rate, the per hour, and kind of do your own bolus mode. But I recommend setting an infusion at like a standard infusion rate and then doing the bolus function. And if you're done administering the medication, just don't infuse the rest of it. Just shut it off. Go to, program it, go to the bolus mode, administer the bolus, and then shut the pump off if you don't want to give them any more You know, if you don't want to give them diltiazem over the next 20, 30 minutes, just shut the pump off. So I don't even remember, honestly, how to get to basic mode. I think it might be... Well, we might have to go back into the... Let's go to EMS. Care area. Oops. EMS. I don't even remember. So I personally don't use this. Basic. There it is. BA, basic. And you just manually put the rates of whatever your concentration is. But it's your responsibility, like I said before, to know how much medication you're giving to your patient and over what period of time. All right, so last thing that I want to go over is just a way to save some medicine. So let's see how much saline it actually takes to flush this. So if you save your cap and you don't get things dirty, let's see. This says this is just over 10. Actually, I'm going to sort it out right to 10 because I'm kind of curious. I'm sure you can find this online, but... Okay, that's right at 10. And then right about there. Okay. It went to like just over 8.5. So I would say probably about 1.2 to 1.4 cc's, which means that if you have saline in this and you connect a medication to a patient, depending on the flow rate, you have to administer 1.4 cc's before the medication even hits the patient. So keep that in mind. So if this is, even if this is 1.5, I could give 6 medications through these using just one flush, instead of drawing up a bunch of medications and using a flush. Because sometimes patients can get too much fluid, and especially if it's a pediatric patient, I would highly recommend either using a stopcock or using this to make sure you don't fluid overload a susceptible patient with renal failure, really bad heart failure, or something like that. And then the last thing that I wanted to say is that, I don't know if everybody's seen these, but the new magnesiums that we have, the old ones were 2 grams and 50 mLs. This is 4 grams and 100. This is twice as much as what your protocol says for, for preeclampsia, it can be 2 to 4 grams, but for hypomagnesemia that causes torsades or something like that, I think it's 1 to 2 grams. So if you administered this whole bag, because it looks like you should, because it's one whole unit, you would give twice as much medication to your patient. So on your pump, let's go back to it, turn it on, I'm going to click mag, and we'll pretend that this is hanging up here. And this is why I verified my medicine before I gave it. So, the 6 writes or 7 writes or however many there are these days really don't go away just because you've been doing this for a while. So let's go to magnesium. Magnesium sulfate. Bring us a little closer. Luckily, there is this concentration, but these are the same. These two are the same overall concentration, but this particular bag is 4 grams and 100 mLs. So we click this, we verify that it's yes, and then it's our primary bag, and rate to be infused. We're going to be giving it as a bolus. So again, do it as an infusion if you want to, but here, volume to be infused, 100 would get you 4 grams. So put 50 here, then you will not overdose your patient, according to our standing orders. So no matter how many bolus modes you do, you will not exceed 50 as a VTBI. It'll say infusion complete. So let's click run. And then when it goes back to its other screen. Oh, interesting. So this one doesn't actually have bolus mode. So this would be your job then to titrate this medication milliliters per hour to administer it over what your protocol says. So if we're supposed to give it over like 5 minutes or 2 minutes, for example, let's say we're going to give 1 gram. 1 gram is in 25 mLs. So if we want to give 25 mLs over 5 minutes, let's say, this is 50 an hour, which means we're giving 25 in 30 minutes. This is about 1 milligram per minute, right? So if we want to give it over 2 milligrams, we'd probably have to run this quite fast, actually. So titrate, let's do, it might alarm at me because I exceed the upper limit, but let's do 200 an hour. Yes, accept. Rate advisory, yes. Now let's see how long this would take to infuse. 200 milliliters an hour. I would give, well, that would be 8 grams in an hour. So over 15 minutes, I'd give a quarter of an hour. So over 15 minutes, I would give 2 grams. So 200 an hour is going to give me my 2 gram protocol in 15 minutes. So if I wanted to make this faster, I'd have to do like 400 or 600, or just do it as like a, you know, hang it over by gravity over 2 minutes, and just kind of time it and watch your drip rate. You could draw it into a really big syringe and push it slowly if you want to, but that takes time. So yeah, there's not always going to be an ideal way to set these pumps, and that's kind of the point of all this. It's your job to understand that you might have to go into basic mode. You might have to do a bolus function. On this one, there wasn't a bolus function, which is a little bit annoying, to be honest with you, because I could then give my own bolus, or I could go into basic mode. But you have to do med math, that's the point, or just administer it over roughly the amount of time that the protocol says to administer it by drip. But know that that can be dangerous, because if you forget, you might give 4 grams of magnesium to a patient if you forget that that's running, or you might give 100 milligrams of diltiazem to a patient while it's running, and if that happens to you, it is your fault. So just be careful when you're administering medicine. I recommend using a pump and getting familiar with how to like kind of program the pump to where you can sort of give what the protocol says to give over the amount of time that it says to give, you know, plus or minus a couple cc's, plus or minus a couple minutes. Not really a big deal unless it's an ACLS medicine that you're giving for like cardiac arrest, you know. But anyways, that's that. Okay, thank you.